speaker, and she was speaking about developing a digital future for pathology. And Dr. Martin, the stage is yours.
Thank you very much indeed, and thank you very much to the organisers. You've had a very interesting programme today, and I'm going to be talking about digital pathology and the future. I'm going to share my screen with you, and here we go. We are going to be sharing screen, and can you see that fine? I'm going to assume that you can see that.
Yes, perfect.
Thank you. So I come from one of the biggest healthcare organisations in the UK, which is Barts Health NHS Trust, and I work for Queen Mary University of London. And I've seen lots of amazing different digital developments over the last few years. I'm passionate about digital pathology, passionate about the opportunities we've had in this area. I'm going to share some of that with you. I'm going to talk about what is digital pathology, what's going on now, and some of the new digital systems developments that we've got going on at the Royal College of Pathologists, just as a taster for you. So when we talk about digital pathology, basically most of us in histopathology are basically, we hack wax. So we take wax slides, wax sections, very thin wax sections, so we can transilluminate them and we put them onto glass slides. The steps in terms of traditional, I'm talking about traditional as in the past 10 years, digital pathology, is to then scan those slides. And this is where it gets interesting because of the capabilities of this technology. We know that it means that you can sit at a desk anywhere you like, you can sit at home and look at sections. We know also that in not having to walk around the lab and go and get slides from the files, we can achieve an efficiency gain. And that efficiency gain is really important in the context of our global work shortages in cell path. So we know that in the UK, as in many countries, there's about a 25% shortage of consultant histopathologists. We're training more and we're doing more, but actually being able to share the work, being able to work more efficiently and more flexibly is really important. We all have colleagues who perhaps break a leg, and previously, without digital pathology, they wouldn't be able to continue working because they couldn't get into work. But now you can actually work from home. Now, I'm not suggesting that you should work while you're sick or ill, but it gives you more flexibility to do that. We know that several colleagues are prepared to stay in the workforce rather than retire early because of the flexibility that the digital capability gives us. So it's helping stabilise our workforce at the moment, but we know that probably 5%, probably single figures, maybe even less than that, of departments have access to digital pathology in this classic form. There are some pathologists, though, who have really embraced this. And there's particularly the IDEX network, where you've got 87 pathologists globally linked with 28 scanners, and they'll be reporting 24/7, 365 days a week from all over the world. The interesting thing, though, this is a network of veterinary pathologists who have completely embraced the networking potential of digital pathology. And this, I think, is a real lesson to us as human pathologists in what can be achieved. When we talk about digital pathology, though, we're also talking about other forms of digitization of images. So for some while now, we've been digitizing electrophoresis gels, northern blots, western blots. We've also been digitising FISH and using image analysis on that to help us highlight chromosomal issues. We've also started to digitise our tracking systems, barcoding of blood tests, and given that we do, certainly across England, we're probably doing 1.7 million, using 1.7 million blood tubes a week, an enormous volume of data that's flying around the system within our digital pathology environment. The other massive amounts of data that are coming into our digital environment as pathologists is genetic data, both single SNP type data, but also increasingly whole genome sequencing. And that whole genome sequencing data is coming in droves. We've got databases at the back end of that, so that you can actually interpret a single patient's genetic changes in the context of a global, increasingly global database. So this digital reach of pathology is increasing day by day. The other thing that we're benefiting from as pathologists is we don't have this anymore in many centres. Now, some centres do, but medical records, I was responsible for those once across a large trust as we were trying to change from paper to digital, and paper archives can be fine in certain circumstances, but when you have a problem, then that's particularly troublesome. And as we move to digitising our electronic records and having electronic patient records, this is not a real patient, this is a test one, and this is a sort of basic view of the sort of summary data that you can get. You can get pictures of a summary of problems, you can go into it further, and you can get laboratory results at the same time. In our own electronic patient record, BARTS, when you go into it, there's a little hyperlink button that I use when I'm looking at patients, and it can take me to the imaging as well. And as we develop our future in digital pathology, we'll have little hyperlinks where it can probably take us to the pathology imaging, hopefully, depending on the structure of our databases and the way we implement our digital pathology. So that's all coming on apace. But from all this amount of digital data, what's really important is the information, the connectivity, the way we use that data, and then coming on to what we're learning from it and how we can start replacing some of the routine jobs that we do as pathologists with automated solutions. So I've already talked about the digital connectivity and used perhaps the example of the veterinary pathologists, but I'm going to come on a little bit further onto that shortly. So information. Once you start to visualize some of this data, once you start to make the data open, you can start to gain insights about our practice from the data. And this is a publication from a few years ago using CA125 testing, and it mapped it over England. You'll notice that Wales is missing from this. It's because it's an English database, and London is put out as a separate image there. And it looks at the rates of CA125 testing, and that's done by primary care trusts. So that's essentially by primary care regions. And you can see huge variation. So that information from this digital network of data is giving us information about patterns of testing and insights into differences in access for patients to these tests, by region. And this sort of information is really important, not only in demand management. So, why are some areas, testing quite as high as they are doing, and why are some areas not doing any CA125 testing at all? So their patients are probably missing out. Other areas, their patients may be being over-tested. Now, the truth lies probably somewhere in the turquoise region in the middle, but the data that we get needs to provide us with information that we use. If you look at an example of it closer to home for pathologists, so cervical screening, this is data taken from the Cancer Research UK databases, which are available publicly, so you can look at insight from national screening programs and national mortality related to cancer. You can see on the left, there's the rates of cervical screening. So the percentage uptake of cervical screening in eligible women. And you can see that there's a 4-point difference between Cumbria and Central Lancashire, and that Cumbria's has a higher than average rate of cervical screening coverage. If on the right, you then look at their cervical mortality, you'll see that Cumbria has a lower than average rate of cervical mortality. Now, obviously, it's tempting to have a causal link between the two, but this is just data giving you insights. But this sort of using data, using the full digital capacity of our pathology systems, is where we can provide better value, better fairness, and better insight for our patients in the types of care that we give. I mentioned digital connectivity and what the vets have done, veterinary pathologists have done in the IDEX network, but cloud solutions are becoming cheaper. Cloud storage is becoming cheaper, relatively. Obviously, if there are any suppliers on, it's far too expensive and we'll need it much cheaper. But it is coming down in cost, and there are some big suppliers who are finding very innovative ways of bringing down that cost of storage, which then enables us to share images, to share our data between different environments. It also is coming onto the stage where we'll be able to share directly with patients, as well as with colleagues, exactly that type of data. We'll be able to show patients images, we'll be able to give patients their reports, and that will in itself give us challenges. So the NHS has committed to making test results available to patients. I think if I think about my reports, and I'm sure if you think about your reports, I'm not sure many people would be able to understand fully the content of those reports. So we've been in the situation, particularly from my point of view, I met with a family who had a copy of a report from a different pathologist in a different sector, and I've been asked to speak to them because they were upset. And they were upset because they hadn't been investigated for histiocytosis. And when I started to talk to them, it was very clear that it was a lymph node, and the lymph node had said it had sinus histiocytosis. And they'd gone to Google, looked it up and said, well, why aren't we being investigated for histiocytosis? And so some of the terms we use, particularly when you don't read those, you don't know about them, can be very confusing for patients. So it's a challenge to us as a profession as we develop digital pathology, as we develop digital solutions, to make our wares, to make our reports more user-friendly. Now I'm going to have trouble with that with mine, I know, and I'll have to think hard about how I present that. But it's going to be an interesting time. The other element, and we've got some very good talks on this coming up throughout the conference, is automatic. So AI, automated recognition. So a development of the machine learning that we're familiar with into a more sophisticated form of AI. Now, we're used to using this every time we go through an airport. So we put our passports into the machine readers and they check our data. It checks our picture against our visual recognition, against our passport photo, and says yes or no. So we're using this side of technology as part of everyday life. Customs officers look at your bags and there's a circle for high risk particular areas. But if we think about the jobs that we do, there's lots of things that the digital landscape of the future in pathology will let us do much more easily. I really don't want to spend 45 minutes looking for a single acid alcohol fast bacillus, a mycobacterium on a Zell-Nielsen. If I can have any suspicious areas on a ZN highlighted for me quickly, that's going to save me some time. I only need to see one decent TB organism to say I've seen a mycobacterium, and that sort of technology will make my work easier. And similarly, automated image analysis, mitotic rates, all that sort of recognition is coming our way in our digital future. The one area I think people have concentrated on less and we've paid less attention to is actually education in the era of digital pathology. There's a very influential report from Eric Topol that was commissioned by Health Education England and the Secretary of State. And that report was basically saying that we've got this amazing informatics, bioinformatics, digital community of practice. We've got this amazing technology coming on, and we've got a whole workforce that is not that well prepared for it. So how do we move pathology forward in the era of digital? There are some really interesting innovations. So learning has got more immediacy. So Twitter's been a tremendous tool for helping educate. I follow Volcano Labs. It's very good with renal pathology. And people like Gerard Gardner, colleagues, Sanjay Mukherjee, all of those have got real insight. So it's a way that experts can share learning items with the community really, really quickly. So you can learn in the moment, so this bite-sized learning. There's other tools. So some of you may be aware of Duolingo. So Duolingo's got nothing to do with pathology, but it's helping to teach me Spanish very slowly and very badly. But I can do 5 minutes a day. I very confidently tell a restaurant now that I don't eat turtles. Other than that, we've developed, just from Barts and Queen Mary, we've developed the ECPD app, where you can get free, quick learning modules on your phone. And that's not designed for immersive a learning experience. It's not for a deep and interactive experience. It's quick. It brings you bits of information that are really useful to know, and it brings them quickly. So it's very easy to put modules up. You can put a module up in 3 minutes, and it's very easy to do, and it's free. So these sorts of learning approaches are coming our way as well. Some are already here. Leeds has shown the way. Leeds is one of several virtual pathology sites where you can learn pathology. Very, very good coverage of slide libraries and mixed slide sets, and open access as well. So you can look at various slides, whole slide images on this site, and that's a real benefit to the community. So some of these virtual learning sites are really, really helpful. What there isn't, though, we came to realise that there was not much that was progressive. So there are lots of slide collections, a bit like stamp albums, when you used to collect stamps when you were little, from all over the world, and we put them in the book, and then you find a new one and put that in the book. And a lot of these slide collections, the equivalent to my old teaching set, I used to have a teaching set, are not really aligned to the curriculum, and it doesn't mirror the way that we train. It's been very interesting that we train machines in a graded way, but we train pathologists in a slightly ad hoc way because it's much more experiential. And we know that some people working in particular sites have less access to certain types of material than others. And often the material is not graded. It doesn't start you off easy. Often on your first day, you'll be faced with a bone marrow trophine or something, and you just don't understand what any of the cells are. You learn, and you learn very quickly. But supporting progressive learning is not something that's really been addressed to date. And the Royal College of Pathologists, in association with Health Education England, are about to launch the new online learning platform here. And this platform is to align digital material to training programs, so progressive, stages 1 to 5 as you go up through training, or 5+ once you're an established practitioner. So being able to refresh, I would find very valuable on inflammatory bowel disease or areas within my practice. Or again, if any of us make a mistake, it's nice just to go back and have a resource that you can check up on yourself sometimes, and just reassure yourself that you're learning well on that. It's graded learning, equal access, and an ability to demonstrate competence. So it will have tests that you can pass, and you can print out a certificate that can help with your assessment of your training at a particular level. We'll be able to do workshops and courses on it, and you'll be able to do dip in, dip out learning at any stage during your training, but also post-qualification. When we think about a typical learning flow, you have a clinical case, you create it as a learning module. So here we create it as a virtual slide tray. An initial question, particularly when you have a virtual slide tray, it might be not what is this entity if it's a complicated one. The answer might be, actually, I don't know, I would ask my colleague. And that will be the right answer for a level 1. For an established consultant, actually, it might still be the right answer. So if I get something unexpected or something different or something difficult, I will go and show a colleague, and that's safe practice. So when as we develop this platform, it will be to mimic training, the natural flow of training, much more closely than just having collections of slides that you can go and see. It'll be perhaps a tray of normal appendixes spiked with one that might have a diverticulum in, one that might have a carcinoid in. And the trick when you start is not being able to diagnose those necessarily, but it will be able to spot that they're different and that they need separate attention. And then as you progress up, you would be expected to get that diagnosis. So this adaptive and conditional learning is being built into this portal. We'll be able to combine not only the histopathology and some of the digital stuff, but with images, both clinical and X-ray images, and also data, in just the same way as we would do for a single integrated hematopathology diagnosis. We'll be able to bring a range of data to mimic normal practice. These are some images from the the beta site, and everyone on this call, will be able to contribute cases. You can put the pathology of megarectum up here. So we've just published an extremely big paper on this, I say so myself, the pathology of megarectum. And then you can ask questions. You can put so this particular module has a link to the review paper, and then it has questions with pictures. So it says, what are these particular structures seen in the muscle layer of the colon? And then it would give you this is a single best answer question. So as a test, I put inclusion bodies here, and it will give you a response saying it's a good answer, but there's a better one. And if you do the better answer, it's polyglucosan bodies. These are actually polyglucosan bodies within the wall of the longitudinal muscle of the rectum. And then the feedback here is option 4 is the best answer. And then you can put additional pictures in, you can put videos, you can have a talking head. So when you've got a case that may be a bit controversial, you can put into that case, you can put into that question a discussion as to why it's difficult or what different people might do. We all know that we use different approaches sometimes, and having that feedback to the trainee, it mimics the training environment much more closely. So you can add in that little bit of human contact. I think that's the other thing that we need to be careful of where we're doing in the digital environment. We love our colleagues. We like to talk. We're social creatures, and also all of you are role models. You're role models to your trainees, you're role models to your students, and to each other. And actually seeing colleagues as, even if it's just talking heads in flesh and blood, is a lovely way of making sure that we retain that human element. And as pathologists, I've always said, to know us is to love us. And so the more we can bring that within this learning portal, the human element of the digital learning, I think that's going to be very, very appealing. One thing is this portal is not just for CellPath. This is for all our range of 17 different disciplines. So the CellPath includes cytopathology, neuropath, oromaxillofacial, neuropathology, pediatric and perinatal. So this will be all covered by the portal, and that will add to the richness. So with microbiology, their microbiology insight into particular cases will feed into our autopsy pathology. It may feed into our skin pathology. If you've got a case of ORF, it's useful to know a little bit about the microbiology or the virology of ORF, so that you can make a better informed differential when you get some odd viral condition of the skin on biopsy. So that's where we're getting to with the online learning platform. We've had lots of fun doing this, and you are welcome to join. You can join in. As we get to the future of our digital offer, it's tremendous to see this sort of stage where we're moving from somewhat antiquated laboratory information systems and digital systems into the digital future. We're not quite at the stage where we're doing minority report type hand-waving control of our digital systems, but we're not far off. So on that note, I'd like to say thank you, and I'm going to stop sharing and return to you for any questions or comments.
Well, thank you, Dr. Martin, for this very comprehensive overview of digital pathology applications, future options, and the present, especially in the UK. I think this is very helpful and very interesting. Any spontaneous and direct questions from the audience?
I have a question, please. This is Lubab. I'm from New Jersey, United States. My question is, should I open the video? Okay, I'll open the video. All right. Yeah, my question is like, are you now like using digital pathology for primary diagnosis, for example, mainly breast cancer?
Okay, so in the UK, 5% at the moment are using primary diagnosis, and that will increase. We're expecting to see by probably the end of the year about 15%, and then it will increase rapidly. Most of our regions in the UK are going out to tender for digital pathology solutions at the moment. There are very few that are not actually implementing digital pathology. You mentioned breast cancer. Yes, there are some people doing primary diagnosis on it, but we've got some interesting regulatory issues around breast screening. So yeah, so in the UK we have the National Screening Committee, which regulates, which puts rules around reporting and quality standards. And some of those quality standards include that you can't use digital pathology for primary diagnosis in screening cases. You can for symptomatic, but you can't for screening. You can do your EQA, your quality, your quality, if you like, tests on digital, but you can't actually do the reporting. So we're working nationally to adapt that. The reason for that is because the national screening program in the UK is all evidence-based, and unless there's a controlled trial demonstrating that it's equal or better, then we don't implement it. So, and the speed of technology has sort of outstripped the regulatory environment. I mean, we found that with COVID too. As COVID has gone out, everywhere is having to, in the US, you've had derogations from the FDA for drugs and tests and all sorts of things.
Yeah, the same thing actually.
Yeah, it's where you've got rapid rollout. That's exactly what happens. You get behind. Are you using it for primary diagnosis?
No, actually, it's not FDA approved yet. So yeah, that's why I asked you the same question. Thank you.
It is. Right, pleasure. I think we've got some. I don't know whether we've got some more questions in the chat box. So in the chat box, hi Sadia. So digital pathology and our own cell path. So that digital is coming out, and the digital teaching will come up in September the 6th. I think we're looking to launch the portal on that. So we've got, I think, £3 million to put the digital pathology system into our own department. Obviously that's going to take a few months to roll out, but then the Path portal will be available for initially ST1s, but there'll be material on that relevant to all specialties. I think there'll be a whole set of neuropath very, very quickly as well on that. Somebody asked about, are we all going to be replaced? Is AI going to replace us all? Get asked that quite a lot. So no, I think we're going to be, it's going to be diagnostic support. I think it's going to be information for us. I think there are some jobs that we may well delegate to AI. I think if you're a hematologist or a hematologist looking for malarial parasites or babesiosis, then actually exactly as I said, highlighting areas of abnormality within a blood slide is actually much more efficient. So it depends a little bit on what you're looking for. So if you're looking for malignant cells or if you're looking for odd abnormalities, but if you're looking in a patient with a patient returning from abroad with a fever and you're looking at a blood film, actually the ability to pick up a parasite quickly is actually very helpful. And there's some very good initial packages on that. Other people are also looking at, we know that some of the firms have been looking at picking up H. pylori from an H&E rather than using a crucifast violet. We know that also picking up areas of dysplasia in colonic or gastric biopsies are tools that many places are looking at. The other thing that AI can be used, not necessarily as primary diagnosis, but as QA. So if you had essentially a machine learning system just saying, hang on a minute, are you sure about this one? I think that can be quite helpful. If you think if the AI oversight picks up an area that doesn't match with what your diagnosis was, then it's always worth a second look. So that quality control, I think many of us have struggled with the time and the effort it takes to audit cases, particularly under a heavy workload. So having automated systems that might be able to review at least some of that workload may be helpful. I don't see we're ever going to be out of a job. Not even our trainees, not even our medical students or scientific students are going to be out of a job in pathology. There's always going to be a job. We might be going to the more difficult end of the market, so looking at the much more difficult cases, but it will be a tool rather than a replacement. I don't know whether there are any other questions there. There are tremendous, there's some really interesting big national programs around. So in the UK, I think the UKRI supported two big pathology-based programs, the NPIC, National Pathology Information Collaborative, and PathLake, and they're both big multi-centre, tens of millions of pounds invested in looking at pathology developments around AI. So we've got some real centres of expertise in and around the nation in this, and I know that's the same in Germany and elsewhere. I've seen some fantastic stuff from the Dutch as well, looking at combining mass spec with image analysis, where you can actually locate proteins. So I'm looking forward to the stage where we replace our immunohistochemistry with a mass spec overlay, so that you can actually not bother with immuno anymore. You can just put the data file up and say, I'd like an epithelial data file. Are these epithelial proteins present in this particular area of the slide? So that one, I'm hoping I'm still alive for, to see that one in practice, but we'll see.
Thank you so much.
Thanks, Andrea.
For this very interesting discussion and good interaction. It's always good to have some questions and answers, because it reflects the speaker's efforts to teach something and to forward some information. So I hope this session will be as interesting as that. So then we would go further on to our next speaker,